Okay, fine. So thank you, Ravi. Thank you, Jamshed. Thank you, Bina Rai. Okay. So first of all, let me give you some clarity, like what is the purpose of these sessions. Uh, as you all know that the date has been released for the upcoming FMG exam, and it's we are having a very short time with us to prepare. And actually most of the students, they are in a lot of confusion, like what to study, how to prepare. So what I'm doing, I'm just trying to engage the student in some sort of studies. I'm just trying to go with some ultra important topics which are repeated over the years, and therefore this the name of this series is expected 300 topics, right? So this is additional to what you will be preparing. You can just continue with your old stuff, whatever you were reading till now. So do revise that, and this is just an additional matter to just you can say for revision, right? So today I have taken 5 important topics, and these are from orthopedics. And yes, these 300 topics I'll be keeping as per the weightage which is given to us as per the NB, right? So today I'm just keeping 5 topics from orthopedics, and yes, as we go ahead, we will definitely improvise more as per the feedbacks, right? So for today's session, I have chosen 5 very important topics from orthopedics, and I'm very sure you will enjoy the session. So we can start the session, and the very first topic is dislocation of shoulder joint. Now, as we all know that shoulder joint, because of its anatomy, it is one of the joint which is extremely susceptible to dislocation. So if there is any question which asks you about the most common joint to dislocate, the answer has to be shoulder. So we will write shoulder here. And once dislocated, there is high tendency for shoulder to dislocate again and again. So if there is something like about the joint which has a tendency to dislocate again and again, the answer again has to be shoulder. Right? So shoulder joint, once dislocated, and if you don't treat it properly, it has tendency to dislocate again and again. Now, depending on the movement of the head of humerus with respect to the glenoid cavity, it can go in front, that is anterior. So right, so one type is anterior, when the head of humerus comes in front of glenoid, or there is possibility that it go behind, so that is posterior, when the head of the humerus slips behind the glenoid. And third possibility is that it can go downward, so that is inferior. So if it slips downward, that is inferior. So anterior, posterior and inferior. Now out of the 3 types which we see very commonly in clinical practice is the anterior one. So anterior one is the one which is very commonly seen in clinical practice. Uncommon type is the one where the head of humerus slips behind the glenoid cavity, and that is obviously the posterior. Now, whenever there is a case history which relates to the posterior shoulder dislocation, there are 2 important clues in the case history. So the moment you have any word which start with the alphabet E, think of posterior shoulder dislocation, right? So one of the E is epileptic fit, right? So one of the E is epileptic fit, and the second E is electric shock. So if you see any E in the case history and there is some indication of shoulder dislocation, most likely it is going to be a case of posterior shoulder dislocation. And if we take a X-ray, we will see a electric bulb sign. We will see a electric bulb sign. So here you can correlate electric shock, electric bulb sign. So anything related to electricity, think of posterior shoulder dislocation. And the rarest one which we hardly see in clinical practice is the one where the head of humerus slips below the glenoid cavity, and this is inferior. Clear? So, inferior one is the rarest, and this is also known as subluxio erecta. So, this is also known as subluxatio erecta. Clear? So, the head of humerus, it comes beneath the glenoid cavity. So, subglenoid region, and the arm is almost abducted and the arm is touching almost the ear. So, therefore, it is known as subluxatio erecta. Clear? So, these are the three types: anterior, posterior and inferior. Now, the one which is extremely important from exam point of view is the anterior one. So, in anterior, what we can see, this is the glenoid cavity here, right. So, if you see, this is the glenoid cavity, and look at the position of the head of humerus. So, this is glenoid, this is head of humerus, and now it has moved anteriorly. So, this is a classical X-ray of anterior shoulder dislocation. Now, the mechanism of injury, how it happens. If the upper limb is abducted and externally rotated, and particularly if there is a push from behind, there is high chances of anterior dislocation. So, abduction, external rotation. So, you can, in short form, you can write ABIR, abduction, external rotation. Now, if you look at the X-ray, what we see, this is the head of humerus and it is lying below the coracoid process. So, this is the coracoid process here, this is the head of humerus. So, it is lying below the coracoid process. So, the most common subtype of anterior shoulder dislocation is subcoracoid, right. Sub means below. So, the head of humerus is lying below the coracoid process. So, this region, this is the coracoid, right. So, these are the important things which you should know about anterior shoulder dislocation. Now, there are certain clinical tests which are only of theoretical importance, should not be done clinically as they are extremely painful. So, one of the tests is the Dugas test. Clear? So, one of the tests is Dugas test, where we tell the patient to touch the tip of opposite shoulder. Now, if there is no movement at the shoulder, obviously the fingers tips, they cannot reach up to the opposite shoulder. So, patient is unable to touch the tip of opposite shoulder. So, this is Dugas test. Then second is Hamilton ruler test. So, the second one is Hamilton ruler test. Now, ruler is actually a scale. So, what we do, we put a scale on the lateral aspect of the arm, and normally what happens, it is not possible for us to touch the tip of acromion process with the tip of lateral epicondyle, right. So, this is okay, and sorry, this should be here, right. So, this is Hamilton ruler test. Right. So, this is, I am sorry, this should be here. So, what actually we do, we put a ruler or a scale on the lateral aspect of the arm, and we try to see if we can touch the tip of acromion with the tip of lateral epicondyle simultaneously. So, normally one cannot put a ruler touching the acromion with the lateral condyle of humerus simultaneously. And why? Because you can see here, this is the prominence of deltoid. So both the landmarks, acromion and lateral condyle of humerus, cannot be touched simultaneously. But yes, if it is dislocated anteriorly, the acromion and the lateral epicondyle, they lie in a straight line, and this ruler can touch both the landmarks simultaneously, right. And the third one is related to the vertical circumference of axilla, and that is Callaway's test, right. So there is an increase in the vertical circumference or the girth of axilla, and what is the reason? See, this is the head of humerus here, this is glenoid. Now if you try to measure the girth of axilla vertical like this, it will be like this. But now what has happened? The head of humerus has gone down. So if we try to measure the girth of axilla, it will be something like this. So the vertical circumference or the vertical girth of axilla will increase, and this indicates that there is anterior dislocation of shoulder. So that is Callaway's test. So there is increase in vertical girth or circumference of axilla as compared to opposite side. So these are the three important clinical tests which are asked, which are very important from exam point of view. So Dugas, Callaway's and Hamilton-Runner test. Now remember, any dislocation is an emergency, right. So it is an emergency, and for dislocation we need to relocate. So what we need to do? We have to reduce the dislocation. So reduce the dislocation, and here the maneuver which is very commonly asked in exam is the Cocker's maneuver. So Cocker's maneuver, and the different steps in the Cocker's maneuver, they can be remembered by the mnemonic TEAM. So T stands for traction. Clear? T stands for traction. Now what does traction means? What we will do? We will pull the arm downward. So that is known as traction. After that, E stands for external rotation. So E for external rotation. Now external rotation means we need to rotate it like this. So external rotation. After that, we have to bring the arm close to the chest. So that is adduction. Okay. So in adduction, what we will do? We will bring the arm close to the chest. So that is adduction. And finally, the alphabet M stands for medial rotation. So this is medial rotation, right. And what is medial rotation? We will rotate it like this, and the tip of the affected side, they will touch the fingers, that the tip of the fingers will touch the tip of shoulder joint of the opposite side, and that will indicate that yes, we have done the reduction properly. So this is just from exam point of view, Cocker's maneuver, and these are the 4 steps: traction, external rotation, adduction and medial rotation. Now complications is very important, and it has been asked many number of times. One thing I already told you in the beginning, that once a shoulder joint dislocates, it has a tendency to dislocate again and again, and that condition is known as recurrent dislocation. So once dislocate, it will dislocate again and again, so recurrent dislocation. Now which nerve can be damaged? So if you know the anatomy, there is one nerve like this, and this nerve is axillary nerve, right. So there is axillary nerve like this, so high chances of injury to the axillary nerve. So we will write here axillary nerve. So 2 important complications: axillary nerve damage and tendency for recurrent dislocation. Now once the dislocation is happening again and again, now what will happen? The head of humerus will strike the glenoid rim, right. So, this is the glenoid rim. So, what will happen, as the head of humerus is moving forward again and again, it will strike the glenoid rim. So, there will be some changes in the head of humerus because it is a cancellous bone, and there will be tearing of the glenoidal labrum as well, right. So, we can see this part is all glenoidal labrum, and this is glenoid cavity proper. So, the glenoid labrum will detach from the glenoid fossa. So, that is known as Banker's lesion. So, Banker's lesion, it means that the glenoidal labrum is torn from its attachment of glenoidal fossa, and there will be indentation fractures in the head of humerus because the glenoid is pretty strong and the humeral head is relatively weak and porous. It is actually cancellous bone. So, there can be indentation fractures, and that is known as Hill-Sachs lesion. Okay, so, that is known as Hill-Sachs lesion. Now, these two findings are seen in recurrent dislocation. So, Banker's, tearing of glenoidal labrum, Hill-Sachs, indentation fractures of humeral head. Now, sometimes students, they mix up how to remember Banker or how to remember Hill-Sachs. So, here you can remember H for humerus, H for hill, and this is actually humeral head. So, you can remember 3H, hill, humeral head. So, that will avoid any sort of confusion. So, these are the important points which you should know from shoulder dislocation, extremely important from exam point of view. Then second topic is hip dislocation, and I think all of you must agree that almost every year we have a question from this topic. Just like shoulder dislocation, anterior and posterior, we have anterior hip dislocation and we have posterior hip dislocation. So, one of the type is anterior, the another type is posterior. Clear? So, this is same as that of shoulder. Anterior means the head of humerus, the head of femur, it will come to lie somewhere in the front of acetabulum. So, this is acetabulum. So, the head of femur will come to lie somewhere here, and posterior means the head of femur will go behind the acetabulum. So, anterior and posterior. But the third one is slightly different, and this is central fracture dislocation. Now, the third one, which is very unique to the hip joint, is central fracture dislocation, where what happens, the head of femur, now this is acetabulum. So, the head of femur, it will perforate through the floor of acetabulum and it will come to lie in the pelvic cavity. So, such fracture is known as central dislocation or central fracture dislocation. So, the three types of hip dislocation are in front anterior, behind posterior, and through the floor of acetabulum central, right. So, anterior, posterior and central. Now, out of the three entities, the most common is posterior hip dislocation. So, this is posterior hip dislocation. Now, the common mechanism for posterior hip dislocation is when somebody is sitting in the car and if there is an accident, the knee strikes the dashboard and then there is a axial pressure which is transmitted through the shaft of femur, and that takes the head of femur out of the acetabulum. So, this is also known as dashboard injury, right. So another term related to posterior hip dislocation is dashboard injury. Now, I think this image or this particular point you must have read plenty of time, like what is the attitude of limb in posterior hip dislocation. Now this is very classical presentation, because the moment you look at the patient lying over the couch, just looking at the patient you can say that this is a case of posterior hip dislocation. So let us see what actually is shown in the image, and then it will be very easy for us to remember it in for long time. Now here, one of the thing which we see here is that Sachin, bache, I am good, thank you. Now one of the thing which we see here is that hip is flexed, right? So the hip is flexed. So the very first point you will write here is flexion. Okay. So the one thing which you need to write here is flexion. Now second point, yes, Devesh Singh, bache, I can understand your state of mind at the moment, but I'll request all of you, please try to hold your nerves. 2 months are really very deciding for you, and my inner feeling says that if you can just study well for 2 months, no need to experiment, nothing new, just whatever the stuff you have read before, keep on revising that, try to utilize the time to the maximum, and I am very sure you will have a good result in first week of November. So I request all of you to please try to overcome this state of mental, I can totally understand, and I can associate your feelings right now, but I'll request all of you, please try to stabilize yourself, please try to hold your nerves. The earlier you can come back to the track, it will really help you in long term, right? So please, I request all of you, please just try to get back onto the track as early as possible. And yes, I know it will take a couple of days of time, but I am very sure you will definitely overcome this, because October 31st, I personally feel it is going to be a golden opportunity for all of you, right? So please, and that's why I have just started this session in a hurry, because I just want to make sure that you don't waste your valuable time, right? So I was in no plan to take all these sessions, but some students, they were calling me from since morning, and so I said, okay, I'll do something for you, and just to keep you engaged in studies, and just to start the studies as early as possible. So I am here with this session, right? Ahmed, so bache, I am requesting all of you, please come back to the track as early as possible, and don't waste your valuable time, because the clock is ticking, it doesn't wait for anyone, right? Okay, so moving back to the topic now, I think most of you can answer this particular point, like what is the attitude of limb in posterior hip dislocation. The one thing which I already told you is that hip is flexed. Now look at the affected knee. This affected knee is touching the normal knee, right? So suppose this is normal, this is affected side. So what we can see, the affected side has gone closer to the normal knee. So what is this? This is adduction. Yeah, so this is adduction, right? So 2 point you can write from here. One is flexion, second is adduction. Now what is the third point? So for third point, you have to look at the medial border of the foot. So look on the normal side, the medial border of the foot is like this, but look at the affected side, it is touching the couch. So medial border is touching the couch, and whenever we have this kind of posture, it suggests that there is internal rotation deformity. Very good, Ahmed Bache, very good. So this is internal rotation. So we will write here internal rotation. Clear? So your answer will become Fadir. So flexion, adduction and internal rotation, And if I am saying adduction, how you will say that? Knee touching other knee, right? So this is how we can say with logic that this is adduction. And internal rotation, how you will say that? Because the medial border of foot touching the couch, right? So that is touching the couch or bed, whatever you can say. So please remember FADIR. The moment you find the word FADIR or the clinical presentation of FADIR with respect to injury to the hip region, the answer has to be posterior hip dislocation. Very good, Ahmed, right? Now let us move back to the X-ray. Now if this X-ray is given, how you can say that this is a case of posterior hip dislocation? So one of the thing is that this is acetabulum and this is the head of femur. So obviously we can see that it is out of the acetabular socket. So the femoral head is out of the acetabular socket. But how we will say that whether it has gone anteriorly or posteriorly? So for that we need to look at one important landmark, and that landmark is this one. Now this is normal side, this is affected side. Now which landmark is this? This is lesser trochanter. Clear? So this is lesser trochanter. Now let us see on the affected side. This is the affected side. Now here we cannot see the lesser trochanter, right? This is very prominent on the normal side, but it is not seen on the affected side. So what has happened? Because of internal rotation, the lesser trochanter has gone somewhere here, and it is not visible on X-ray. So in posterior dislocation, it does not mean that the lesser trochanter has disappeared. It hasn't disappeared. Just because of this internal rotation deformity, it is hiding behind the shaft of femur, right? So with this we can say that one of the deformity which we can see here is internal rotation. So this is internal rotation, and therefore the lesser trochanter is not visible on X-ray. Now second of the deformity, suppose if this is the midline, now what you can see, the femur is going closer to the midline, right? If you see here, so this suggests that there is adduction. So this is adduction. Clear? So see, adduction, internal rotation we can also see on the X-ray pelvis with both hip, right? So with this we can say that this given X-ray is a case of posterior hip dislocation. So the only thing for posterior hip dislocation X-ray, right? So the only thing which will help you in reaching a diagnosis is look for lesser trochanter. If you can see the lesser trochanter, don't go for posterior hip dislocation. It is not a case of posterior hip dislocation. In posterior hip dislocation, lesser trochanter will not be seen, okay? And then obviously you can see for adduction as well. So this is one thing. Now one question which is asked many number of times, and yes, it is not exclusive to hip dislocation, is the Shenton's line. So let us draw on the affected side first, on the normal side first. So this is, and if I continue it like this, it goes like this, right? So what I want to show you here, medial side of the neck of femur and the inferior border of the superior pubic rami, it forms a smooth curved line, isn't it? It is forming a smooth curved line. So this line is known as the Shenton's line. So this is the Shenton's line. And if there is any damage to the integrity of the hip joint, it will lead to breaking of the Shenton line as we see here. This is inferior border of the superior pubic rami and this is the medial border of the femoral neck. So you can see there is a break. So this is known as break in Shenton's line. But again I am repeating, it is not an exclusive finding to posterior or anterior hip dislocation. So broken Shenton line. And as we discussed, it is a continuous curved line which is drawn through the medial part of the neck of femur, right, and the inferior border of the superior pubic rami. Clear? So this is the Shenton line broken in case of posterior hip dislocation, but again not exclusive. So I can just write here, not exclusive. Means the moment you see a break in Shenton line, you cannot say that this is a case of posterior hip dislocation. Clear? Now, as I already told you before, if there is any dislocation anywhere in the body, it is an emergency. We have to address it at the first, and what we need to do? We need to do reduction. We have to relocate back the dislocated piece of bone. It can be like head of humerus or head of femur depending on the type of dislocation we are discussing. So here we need to put back the dislocated head of femur back into the acetabulum, and that can be done by Stimson's or Ellis maneuver. Now again moving to the complications, which is very important from any injury. So as we discussed in anterior shoulder dislocation, axillary nerve can be damaged. In cases of posterior hip dislocation, the nerve which can get injured is sciatic nerve, right? So there is high chances of injury to sciatic nerve. Then what can happen? As the femoral head moves out of its normal position, there can be tearing of the vessels which are providing blood supply to the head of femur. And if there is loss of blood supply to the head of femur, the head of femur will become avascular. And once a structure becomes avascular, it will undergo necrosis. So this condition is known as avascular necrosis. Clear? Avascular necrosis. A means without, vascular means blood supply, necrosis means death of the tissue. Third, there can be formation of additional piece of bone, and that is known as myositis ossificans. So although not that important from exam point of view, you should remember two: sciatic nerve injury and avascular necrosis. That's very important. Now moving forward to anterior hip dislocation. Again we can see here, this is acetabulum and this is the head of femur. So now the head of femur is out of the acetabular socket. Now if I ask you which type of dislocation is shown on the X-ray, how you will say? Because it can be posterior, it can be anterior. So what you need to do? Again you have to look at that bony landmark. So this is again normal, this is affected. So I am showing you on the normal side, this bony landmark we discussed previously is lesser trochanter. Now let us mark out this bony landmark on the affected side. Now here you see this stands more prominent, and therefore it suggests as if there is external rotation deformity, right? So external rotation deformity. And secondly, if I draw, suppose if this is the midline, now what we can see, the leg is going away from the midline. So away from the midline, what is that? Abduction. So for anterior hip dislocation, if I ask you what is the attitude of the lower limb, what will be your answer? Firstly, yes, it will be flexion here. Flexion is common to both anterior or posterior. Now the next two terms are exactly opposite to what we have discussed in posterior hip dislocation. Very good, Ahmed, very good. So what we will write here, one is abduction, right? I showed you what is abduction. The lower limb is moving away from the midline, so abduction. And lesser trochanter becoming more prominent, this is external rotation. So now what your answer will be? Faber. So this is how you need to remember. So this is external rotation. Clear? And yes, the answer will be F, A, B and E, R. So is that clear? I think there will be no confusion whatsoever now. Posterior hip dislocation, Fader. Anterior hip dislocation, Faber. Right? So please remember this, and this is a commonly tested concept in exam, and they will try to confuse you. The only landmark which is going to help you in X-ray especially is lesser trochanter. So look at the lesser trochanter. If it is visible enough, hip joint seems dislocated, it is a case of anterior hip dislocation. And yes, if vice versa, if the lesser trochanter is not visible to you, it is going to be a case of posterior hip dislocation. So please, my dear students, don't do any mistake in this. It is simply, it's not expected, right? Now here also the injury, the mechanism will occur when the hip is externally rotated, right, and the abducted. Clear? So you will have anterior hip dislocation. So very easy to identify on X-ray. Now the third one, which I was talking about, when the head of femur will perforate through the floor of acetabulum and it will move inside the pelvic cavity, this is central dislocation or central fracture dislocation. So if you look here, this is the normal side, this is the affected side. In the normal side, we can see a beautiful acetabulum and a congruent head of femur sitting within that. But look at this side, what we see here, the head of femur is going like this, perforating. So we can see the acetabulum is broken like this. So this is central fracture dislocation. Now here what is happening, the head of femur is forced medially. Here it is coming inside and it is forced medially through the floor of acetabulum. It is moving inside and perforating or breaking the floor of acetabulum. Now in such a case, if we do a per rectal examination, we can obviously palpate the head of femur. So the head of femur can be palpated on per rectal examination. As it has gone inside the pelvic cavity, so it can be palpated. So these are the three different variants of hip dislocation, and yes, from exam point of view, you have to be very perfect with posterior hip dislocation. Now moving forward to one more entity which is not only important from exam point of view but also from your clinical practice point of view, and that is fracture neck of femur. And whenever we are discussing fracture neck of femur, we specifically write intracapsular. Intra means inside. So it means the fracture line is within the capsule of hip joint. So if suppose if we take in this diagram, this is the territory of capsule of hip joint anteriorly. So if the fracture is occurring somewhere here, that will be known as intracapsular. If the fracture is occurring somewhere here, it is known as extracapsular. Clear? So the word intracapsular, extracapsular is clear. If within the, so let us, if this is the extent of the capsule of hip joint, something like this. So, this is all capsule of hip joint. If there is any fracture which is occurring within this capsular part, it is intracapsular. If the fracture is occurring here, this is intracapsular. So, that you should remember, because that will be discussed now. So, fracture neck of femur intracapsular. Now, before that we have few classification systems which you should know. One is anatomical. Now, anatomical is location wise. What is the location of the fracture line? One is that it is just below the head of femur. So, if it is just below the head of femur, this is subcapital. Okay. So, sub means below, capital means head. So, it is just below the head of femur. Then one is at the base of neck of femur. So, that is known as basal. So, this is basal at the base. And the third fracture possibility is between these two locations, that is through the middle of the neck of femur, and that is known as transcervical. Now, trans means through. So, this is through the neck of femur, somewhere in the middle. So, these are the three types based on anatomical classification: subcapital, transcervical and basal. Now, remember, out of the three, basal has the best prognosis, right, and subcapital has the poor prognosis. Why? Because this all area is cancellous bone. So, basal has some good chances of union, subcapital poor prognosis. Now, second classification is Powell's classification, and Powell's classification is actually based on the angle of fracture line with the horizontal, right. So, what we do, we take the horizontal like this, and then we see what is the angle of the fracture line with this horizontal. So, this is one possibility 30 degree, this is another possibility 50 degree, and this is third possibility 70 degree. So, this is Powell's classification, like the angle of fracture line with the horizontal. Now, out of the three, this has got poor prognosis and this has got good prognosis. So, lesser the angle, better the prognosis, more the angle, more chances of instability and hence poor prognosis. And the third one is Gardner's classification, which is actually based on the trabecular pattern. And this is again actually a radiological classification, little difficult to interpret. So, Gardner's classification is based on the trabecular pattern. So, anatomical, Powell, Gardner's. Now, what is the mechanism of fracture neck of femur? Now, fracture neck of femur is commonly seen in elderly, old patient, and this happens after a trivial trauma. Trivial trauma means minor injury. So, you can say simple twisting of the leg, maybe in some carpet, or if the toes get stuck in some carpet or like that. So, that simple injury, fracture. So, it means the bones are already weakened, and what is that very common condition in elderly where the bones get weakened? That is osteoporosis. So, therefore, in elderly there are high chances of fracture neck of femur. Now, what we see, once there is fracture neck of femur, there is tendency for the shaft of femur to rotate outside. So, that is known as external rotation of leg. So, the leg of femur, the leg of the patient will rotate outward. So, that is external rotation of the leg. But important thing is that degree is less than 45 degree. It is less than 45 degree. Why? Because of capsule of hip joint. So, the capsule of the hip joint will not allow the shaft of the femur to rotate externally freely. There will be a check, and therefore, it is less than 45 degree. Now, why this point is valuable? Because if the fracture line is outside the capsule, the lower part of the shaft of femur or the leg, it is free to rotate externally, and it can go up to say 60 degree, 70 degree, or till the point where the lateral border of the foot touches the couch. So, this degree tells you whether it is intracapsular or extracapsular. So, I will just write here, if it is more than 45 degree external rotation, then it means it is extracapsular, means the fracture line is outside the capsule, right, extracapsular. So, more external rotation, extracapsular, less external rotation, intracapsular, clear. And this extracapsular is also known by another name, and this is intertrochanteric. Okay, so what is another term for this? Intertrochanteric fracture. Clear? So, this is how clinically we differentiate between the two. Naresh Meal, good evening, bhai, good evening. Clear? So, this you need to remember. Now, here again you can see one line which goes through the medial part of the neck of femur and then going to the inferior border of superior pubic rami, that is broken. So, which line is this? So, if I draw it like this, this is here, but this is here. So, which line is this? This is again Shenton line, right. So, Shenton line is broken. So, that is why I told you previously that Shenton line is not exclusive to posterior hip dislocation, because here we see that it is also broken in fracture neck of femur. And now, look at the lesser trochanter. Lesser trochanter is visible too much. So, it means there is which type of deformity? External rotation, that we already discussed. So, this suggests that there is some external rotation deformity, clear. So, here I will write external rotation, and how it is evident? Because the lesser trochanter is more prominent. But again I am repeating, in intracapsular it will be less than 45 degree intracapsular, clear. So, just remember that. Now, treatment is very very strange here, because for different age group, different treatment modalities, at different period of time, different approaches to treatment. So, here you need to remember two things. Number one, duration of fracture, means what is the time period since injury, and number two, age of patient, how old is the patient. So, here we have different approaches. Now, age, it can be children, and if it is adult, so the second is adult. Now, in adult we will again see whether it is less than 60 years or more than 60 years, clear. So, see, different age group, different plan of treatment, in children's or in adults, and then duration is like less than 3 weeks or more than 3 weeks. So, please remember, this duration is very important, 3 weeks. If the patient comes to us within 3 weeks, then only we will say that the fracture is a fresh case. So, for fresh case means the patient coming to us within period of 3 weeks after injury, the first priority, especially in children and in young adults, is internal fixation. We try to fix the fracture. So in children's, we can use multiple multiple pins like Knowles or Moore's pin, right? So we can use pins for internal rotation in children's. Similarly, in young adults, we can do internal fixation with multiple cannulated cancellous screws. So you need to remember the short form CCS, right? So cannulated, it means the shaft is not solid, there is a hole in that. Cancellous and screws. So less than 3 weeks, children, adult, go for internal fixation, right? So this is. Now in elderly, whether the patient comes to us within 3 weeks or after 3 weeks, what we do, we go for hemi replacement arthroplasty. So this is hemi replacement arthroplasty, right? So H for hemi. Hemi means half. Replacement. So we are replacing half of the areas which are participating in the formation of hip joint. Arthro means joint and plasty means repair. So we are doing repair of the joint. So what we see here, we are actually using, now this is Austin Moore prosthesis here in the, so this is Austin Moore's prosthesis, clear? And what we see here, the acetabulum is as such. Now what we have done, we have removed the head of femur and we have removed the neck of femur. So we have removed only half of the portion of hip joint. So this is Austin Moore prosthesis, and you can see some holes here which are given so as to give space for the new bone to form, so that it can anchor the implant within the shaft of femur. So this is Austin Moore prosthesis, and in elderly, HRA, that is hemi replacement arthroplasty. Now if the patient is coming to us after 3 weeks, now we need to, after 3 weeks there is possibility of AVN. So what we need to do, after 3 weeks we need to check, especially in young, whether the head is normal or it has undergone AVN. So what we will do, we will go for MRI. So after 3 weeks, the very first thing we need to do in adults is MRI, and MRI will tell you whether the head of femur is okay or it is gone. If the MRI shows that the head of femur is okay, vascularity is not gone, no AVN, it means we have to preserve it. So what we will do, we will do osteotomy. So we will cut the bone in such a manner so that we can change the mechanical axis. So we can do two type of osteotomies, either we can do a Powell osteotomy or we can do a McMurray osteotomy, right? So just remember the name, Powell or McMurray osteotomy for fracture neck of femur presenting after 3 weeks of trauma in adults with vascularity of the head of femur retained. So there are many conditions which you need to remember. So more than 3 weeks, young means less than 60 years, vascular head means normal MRI, and then you will do this osteotomy, change the mechanical axis. The other possibility is that we can increase the vascularity to the fracture site, and how we can do that? We can do vascularized muscle pedicle bone graft, right? So we will remove a piece of bone to which a muscle is inserted, and then we will take this piece of bone and we will push it, we will place it on the femoral neck region, and what will happen, by this we are transporting a muscle, and along with the muscle there will be blood supply which will reach up to the fracture site, and if there is good blood supply at the fracture site, obviously there will be good chances of healing. So this is vascularized muscle pedicle bone graft, and yes, this need to be supplemented by internal fixation. So we have two procedures because we can remove two type of muscles from their bony insertion. One is Mayer's procedure, where we can use the muscle which is quadratus femoris, and the other procedure is the Buxy's procedure, where we can employ the same principle but we can use another muscle, that is tensor fascia lata, right, in short TFL. So these are vascularized muscle pedicle bone grafts. Now suppose if the head is non-vascular, the patient is coming to us after 3 weeks, the age is less than 60, it means the patient is young, but the head is non-vascular, so we have to remove it because there is no point in keeping a non-vascular part in the body. So we have to remove it, and then in such cases we can go for bipolar prosthesis, right. So this is bipolar prosthesis. So there are actually two points of articulation within the prosthesis itself, so that is known as bipolar prosthesis. Now coming to complication, one of the complication we already discussed, that there can be damage to the blood supply. So you will call it avascular necrosis. A means without, as I told you before, vascular means blood supply, and necrosis, I think all of you know, death. So AVN is very problematic here, and second, of course, high chances of non-union. The fracture may go into non-union, and the treatment is same as if the patient is presenting to us after 3 weeks. So depending on the age group, depending on the status of the vascularity of the head of femur. So this is slight, the treatment part is slightly confusing, but this is a very valuable topic from exam point of view, and not only from exam point of view. Whenever you go to orthopedic practice, you will see plenty of cases, elderly people coming with fracture neck of femur. So that will be beneficial to you at that moment of time as well. Now the next topic which I particularly feel is very important from exam point of view, because most of the time we have an X-ray based question, and if you can just mark out the findings in the X-ray, you will definitely reach up to the right answer. So this is chronic osteomyelitis. Now chronic osteomyelitis is the most common complication of acute osteomyelitis. If a case of acute osteomyelitis is not treated properly, it will go into chronic osteomyelitis, right. So it is a commonly it is a complication of acute osteomyelitis. Now what is the most common presenting symptom, how the patient will come to you and what he will tell you? So here the patient will come to you with discharging wounds, right, with deformed bone, with irregularity over the bony surface, something like that. But commonly they will say that there are some wounds through which off and on discharge will happen, right. So discharging wounds, and we call them sinus, but the patient will tell you like wound. Now what is more important, the moment the patient tells you like that, I am having discharging wounds, the very first thing which you need to ask the patient is whether there is discharge of any bony pieces, right. So what you will write, bony spicules or bony pieces, and the moment patient tells you, yes, sometimes I can see some small pieces of bones are coming out through this wound, this is a case of chronic osteomyelitis. So this is how we clinically diagnose it, right? So always ask whether some bone pieces are coming out of that wound or not. Okay. Now, what is more important for you to remember from exam point of view are the X-ray findings, and here you need to remember three terms. One is sequestrum. So if you see here this dense white part, this is sequestrum, right? Dense white is sequestrum. So this is sequestrum. Now sequestrum is actually a dead piece of bone, and since dead piece of bone means no blood supply, and if there is no blood supply, it means there is no washout of calcium, osteoclasis. So there is no washout of calcium, and therefore calcium will remain within the bone, and therefore it will appear more white on X-ray, right? So that's why if you look here, it is appearing more white. So it means it is dead piece of bone. There is no process of calcium washout. Calcium is retained as such, and therefore it is appearing more white. Now what is more important, surrounding this whiteness you can see a black shadow. You can see a black rim. Now this black rim is actually the infected granulation tissue, right? So this is the infected granulation tissue. So this is granulation tissue. So therefore the complete definition of sequestrum is it is a dead piece of bone surrounded by infective granulation tissue. So one thing which you need to identify is granulation tissue, very easy to identify. Look for white, firstly look for a black shadow, and within that black shadow if you can see a dense white piece of bone, straight away that is sequestrum. Now secondly, what happens whenever some part of the body dies, body tries to make up the loss. So here a piece of bone is dying, so what the body will do, it will form new piece of bone so as to make up the loss or to give support to the weakened area of the bone, and that new piece of bone is known as involucrum. So what is that known as? Involucrum. So it is involucrum is the newly, now this is newly formed bone, right? Newly formed bone. And what is the purpose? It is trying to give strength to the area which is weakened because of formation of sequestrum, which is dead. So it is just trying to give strength to that portion. So therefore we will see a dense sclerotic bone which is overlying sequestrum. So now here we know that this is sequestrum. So this part is all involucrum. Clear? So sequestrum, infective granulation tissue, involucrum. Right? So these are the two important things which we can see on X-ray. But yes, the moment you see sequestrum, you have to make your diagnosis as chronic osteomyelitis. Now we discussed in history that if there is discharge of bony spicules, that is diagnostic. So the openings in the bone through which those bony spicules are discharged into the sinus are known as cloacae. So multiple is cloacae. So they are the opening in the bones through which the necrotic matter or the bony spicules are discharged into the sinus over the skin. So three terms: sequestrum, involucrum, cloaca or cloacae. Now here the treatment is always surgical. Now what we can do? Sequestrum is there. If you don't remove it, body will try to remove it. So better remove that. So what we will do? We will do sequestrectomy. So ectomy means surgical removal. So we will surgically remove the sequestrum. Sometimes there are incidences or there are some possibilities when the bacteria or the infective matter can remain within the bone. So we need to convert that into a saucer, and that is known as saucerization. and for local delivery of antibiotic we can put antibiotic impregnated beads, right. So this antibiotic is actually gentamicin. Clear? So we will have this bone cement, we will put gentamicin, we will make beads, and then we can put it over a stainless steel wire, and then we will put it over the inside the bone, and that will locally release the antibiotic. So these are methods of treatment. Now complications, you should know there is a condition, I think most of you must have studied in pathology also, that chronic infections, they can lead to secondary amyloidosis. So chronic osteomyelitis is one such condition, then bronchiectasis. So this is one thing. Then because of sequestration, the bone has weakened. So such a bone has high tendency of fracture. So such fractures are known as pathological fractures. And third, there can be cancer formation. So squamous cell carcinoma of the sinus tract. Clear? So these are the three important complications of chronic osteomyelitis: pathological fracture, secondary amyloidosis, or squamous cell carcinoma. Then we always expect one question from bony tumors, and I have kept giant cell tumor. So the very important clue to make a diagnosis related to bony tumor is, first of all, look at the age group. Then second, the area of the bone which is involved. So giant cell tumor, the age group is 20 to 40 years, right? And the bony area is epiphysis. Clear? So 20 to 40 years involving the epiphysis of long bones, especially around the knee joint. So around the knee joint, and whenever we say knee joint, either it can be lower end of femur or it can be upper end of tibia. So this is number 1, this is number 2. So epiphysis, lower end of femur or upper end of tibia. Now what is more important in giant cell tumor is about its histology. So now if you look at the name giant cell, so it means on histology what we will see? We will see the giant cells. Now what actually giant cells are? So look here, you can see a big cell and it has got many nuclei. So such a cell is known as giant cell. We can see this is one more giant cell, this is one more giant cell. So plenty of giant cells which are having many nuclei within them. So such cells are known as giant cells. So one thing which you will see here is giant cell, right? So giant cells, and here we can see multiple nuclei, so it appears larger. Now this tumor was named as giant cell tumor because it was presumed that these are the tumor cells, but that was wrong. These are not the tumor cells. So giant cells are the non-tumor cells, they are not the cancerous cells. So multi-nucleated, many nucleus within the cell, and therefore this nomenclature was wrong, it's a misnomer. Now we also see some cells which are having one nuclei, so such cells are known as mononucleated. Just one cell, one nuclei, so mononucleated spindle cells. So if you see here, all these single nucleus cells, they are mononucleated spindle cells, and later on it was found that they are the actual tumor cells or the proliferative component of the tumor. So the nomenclature of this tumor was done based on wrong facts, and this is also known as osteoclastoma. Clear? So, this is also known as osteoclastoma. That is another name. And X-ray, I think most of you can, the moment you look at the X-ray, you can make your diagnosis. So, location I already told you, that is epiphysis. So, it starts from the epiphysis and it extends towards metaphysis. So, it starts in epiphysis and goes towards metaphysis. So, there is metaphyseal involvement later on, but it does not mean that the tumor arises from metaphysis. It does arise from epiphysis. And if we divide the bone into two halves, we see that the tumor is more towards one side. So, such a presentation is known as eccentric, right. So, eccentric more means more towards one side. So, remember, 2 is epiphyseal tumor, eccentric tumor, and third you can see classical soap bubble appearance. So, I think all of you must be knowing this soap bubble appearance for giant cell tumor. And what we need to do? We need to remove the tumorous part if it is big enough, and then we need to do reconstruction by putting a cortical bone graft. So, here we can put a cortical bone graft, and usually we take fibula. Clear? So, we prefer fibula, right. So, this is about giant cell tumor. So, this is enough for this session. I am very sure you must have enjoyed the session. Very shortly I will come up with some more very important and expected topics for the upcoming FMG. Till then, keep on studying, try to focus, try to stabilize yourself, and I am very sure most of you will definitely clear the upcoming FMG, right. So, with these words, thanks for giving me your valuable piece of time, and we'll meet tomorrow with some more important topics from some other subject. Till then, good night, God bless.